Okay. Good evening, everybody. It is indeed a proud privilege for all of us here at IFS for hosting this seventh episode of Genius Junction. And today's episode is in association with the SIG uh, on the POR, poor ovarian responders. And today we have none other than Dr. Surveen Ghumman with us, who would be talking to us about management of POR, the IFS perspective. IFS, as you all know, has come up with wonderful guidelines on how to do it in the Indian scenario. So here, let us hear it from the horse's mouth. Dr. Surveen's talk would be followed by another talk by Dr. Kokila, and she would be talking to us on ovulation induction in the IUI protocols. And then we would have the quiz on Kahoot, which would be conducted by Dr. Padmaja from Andhra Pradesh. So over to you, Dr. Sylvine. It's a pleasure to hear you always. Welcome on board. Thank you.
Thank you, Manjusha, and thank you for having me on board. I think you're doing a wonderful job with this Genius Junction. So, I am going to talk about ovarian stimulation protocols in poor responder, the IFS perspective. So, just a moment, 1 second. I just to make sure. Yeah. So, when you look at the low prognosis group, you're looking at those which are unexpected, that is 1 and 2, and those which are expected, which are 3 and 4. And that is how Poseidon has divided these. The patients who fit into Poseidon group 1 and 2 should be critically analyzed for two indices. One is the follicle output rate, that is the pool of antral follicles at the beginning of ovarian stimulation and the number of pre-ovulatory follicles. And FOI is the follicle oocyte index. That means the pool of antral follicles at the beginning and the actual number which you actually retrieved. And hyper response is termed as FOT of FOI being less than 50%. So why did Poseidon induce a new marker of success? Because they realized that one euploid embryo is needed for transfer to get a 60% success rate. And they wanted a logical endpoint for clinicians to guide them on individualized treatment on how they can get this one euploid embryo, which would change the fate of low prognosis to high prognosis, because whether it is from a 35-year-old woman or from a 40-year-old woman, one euploid embryo gives the same success rate.
Just excuse me, can I ask everybody to mute their audios? Everybody, please mute their audios. Himanshu, can you mute everybody from the central command? Yeah, thank you.
How does the number become important? Well, the number is very important because there's a certain percentage of euploid embryos, and the number depends on the age, expected aneuploidy rate, fertilization, blastocyst rate, and total number of oocytes. And for this, a ART calculator has been evolved, and they say for young women, 4 to 7 is enough, but for older women, they require more oocytes. And if you look at this, the success as per number of oocytes is, if you have 20 oocytes, the probability of having a live birth in a 42-year-old woman is just about 10%, but in a woman who is younger, under 35, it becomes 90%. So that's how the number becomes important, and it's age dependent. Now, if there's a less of oocyte retrieval, what could be the causes? It could be genetic, environmental factors, a low gonadotrophin dose, asynchronous follicular development, and technical issues involving the triggering. The first step in stimulation of POR, the most important parameter to predict the chance of conceiving after IVF, is the number of oocytes retrieved and the woman's age. An efficient prediction of ovarian response is therefore pivotal to tailor the right regime for this particular patient. So it is basically individualization. How is it that there are certain patients who have a normal ovarian reserve, but they are hyporesponders? Now, this could be because of two genetic variants, the could you just mute? And the FSH receptor variant. So homozygous carriers would require much more FSH compared to heterozygous carriers. And hence you can actually have a pharmacogenetic approach when you're trying to stimulate a patient. When there are these polymorphisms, what are the five main strategies on which you can base your this thing? You could use recombinant FSH in preference over urinary gonadotrophins because they have a higher biopotency. FSH dose can be increased. You could switch over to recombinant LH also along with FSH. Adjuvants like DHEAs, I'm going to be coming to all these, and dual stimulation. So what does increasing the FSH dose do? So if you see group 1, there is the FSH polymorphism. Group 2 also has the FSH polymorphism, but here we're using a higher dose, and group 3 is normal. What you see is that the peak estradiol levels on using a higher dose in these patients is similar to patients who are normal. So that shows that these patients actually require a higher dose of FSH to stimulate in the same manner as a normal patient would stimulate. In IFS guidelines, when we analyzed this, we went over 5,000 articles, and we zeroed down to a few articles where this was discussed. And we did recommend that increasing the dose in hyperresponders will help. How much should the dose be increased? Well, they say that an increase of 50 IU of initial FSH dose would lead to one more oocyte. So, but it actually depends upon also the number of the age of the woman. Coming on to LH and its role in ovarian stimulation, because the next point is that we add LH. Now, LH uh, should be above a certain threshold, but below the LH seal, because there will be atresia if the LH is very, very high. So there's a LH therapeutic window. Let's identify which are the patients who require an LH. Most women have sufficient LH, endogenous LH, that do not require it. Those with deeply suppressed endogenous, like hypo, or they are suppressed by agonists or antagonists, 20 to 30% of women have less sensitive ovaries. They have not been given agonist or antagonist, but they are less sensitive ovaries. These are the older patients more than 35 and the poor or slow hyperresponders to COS. LH supplementation, only useful strategy that can maximize pregnancy. Older women are much better responsive to LH, as can be seen that under 30 the odds ratio is only 1, but when on adding LH the change seen is 1.5 in older women. So there is a higher implantation rate and a higher clinical pregnancy rate with the odds ratio of 1.37. Who benefits from LH? LH could be beneficial in two subgroup of patients. One is the unexpected hyperresponders to recombinant monotherapy, that is Poseidon 1 and Poseidon 2. And second is those with 36 to 39 years of age. What they found is beyond 40, even LH does not help because they are actually poor ovarian reserve. So should you increase LH or add FSH? So if you had a choice of doing either this or that, then I think increasing LH shows that there is a higher oocyte retrieval and a higher pregnancy rate compared to making FSH alone higher. And this is what has been recommended by the IFS guidelines. How much LH should be given? Well, they've said that in an agonist cycle at least 150, and in an antagonist cycle 75. It can be started in the mid follicular phase of the antagonist cycle. And when should it be added? Agonist, it should be right on the first day. Antagonist, when you start the antagonist. And in the first cycle, that is right from the beginning, when stagnation is observed on day 8, it's your first stimulation, and day 8 you've got stagnation. Add LH and the patient will respond. What about androgens and DHEAs? Well, we know that older patients have lower androgens, and androgens do help the preantral and antral follicles to develop, and decreased ovarian reserve at all ages appears to represent an androgen deficient state. In the earlier studies, it was shown that clinical pregnancy rate and live birth rate are better because the aneuploidy rate decreases by supplementing with androgens, and this reduced aneuploidy rate leads to reduced miscarriages and hence a higher live birth. But the effect is not there in the younger patients, it is more in the older patients. Duration of treatment should be at least 2 to 10 months. At 2 months it starts, but the highest point of effect, that is the rate of pregnancy, increases by 10 months. But there's conflicting evidence, and it is seen that there's insufficient evidence to draw any conclusion. However, there was a recent Cochrane review of 2024 which says that testosterone does have some effect. Now, in IFS, we have not advocated these because of simply one reason, that there were not enough randomized controlled trials. Secondly, the trials which were there were not of good quality. And thirdly, the harmful effect was not discussed by any trial. That means the impact on the fetus long term was not shown. What about growth hormone? Well, there are growth hormone receptors on the granulosa cell, and growth hormone helps in recruitment of the primordial follicles and prevents the atresia of the antral follicles. But what was seen? It was seen that M2s increase, 2PN increase, number of embryos increase, but the implantation rate and clinical pregnancy rate, there was no significant difference. And this was also seen in a recent meta-analysis by Cozzolini in 2022. I do use growth hormone. I find a difference, but again, I find a difference in the number of oocytes retrieved, not in the final pregnancy rate. So IFS, again, because the harmful effects were not discussed, we did not recommend it. Estrogen in luteal phase, why is it given? It prevents the premature rise of FSH and decreases the follicular recruitment and prevents discordant growth and cancellation of the cycle. Then again, this luteal phase estrogen was not recommended by IFS because there were no strong studies showing that it had a good impact or it definitely helped. This is how it's given. You give the either the estrogel, or you can give the estradiol valerate from day 22 till the period, and then you'd start the stimulation. What about duostim for poor responders? Well, the first ovarian cycle is like any other, then the trigger is an agonist, and then after 4 days, you start the second cycle. And there may be a menstruation in the middle. The second trigger can be HCG or GnRH. And most significant is that the dropout rate is decreased. Are the results different in follicular and luteal phase? No. The fertilization, blastocyst, euploidy rate are all same. And the only thing was that in the luteal phase, the response, non-responders were higher. The BISTIM study stated that there was no benefit of duostim versus 2 consecutive cycles. They said it is the same. And IFS guidelines have not recommended it. There are certain strengths and weaknesses and threats. And the main one is that it exploits the anovulatory waves of follicular recruitment should undergo thorough biological clinical investigation, because it is taking out those oocytes which would naturally not have ovulated. So we do not know what the long-term impacts are. And even Eshrey has said that double stimulation should only be considered where there's an urgent fertility preservation cycle and should not be used in normal. What about the trigger and POR? Well, if you look at this, the number of oocytes with a dual trigger, that is HCG and triptorelin, is less compared to only HCG, but the clinical pregnancy rate is so much higher, 22% versus 8.8%. And they have said that a dual trigger is better for poor responders. What about dose? With a higher dose, you find that there are higher number of oocytes retrieved and more mature oocytes per retrieved follicle. So definitely maybe a higher dose in poor responders may help. When to trigger a poor responder? That's very important. Even one follicle, one oocyte is important for these people. So does a large follicle mean that it's not going to give a oocyte? No. You see it, the large follicles more than 24 are also giving oocytes, same fertilization rate, and in fact a higher top quality embryo rate. So if you have a discordant growth, and let's say one follicle or out of 2 or 3 has reached 20 mm, it doesn't mean you trigger her. You can take it to 22 while the other ones grow to maybe 16 and then trigger her at that time. You will definitely get an oocyte. What about the smaller ones? We often leave the 8 to 12 mm ones, but look at that. The oocyte recovery and fertilization rate and blastocyst rate are equivalent in the 8 to 12 versus 13 to 23 mm. So you should aspirate all the follicles, and they should be encouraged that all the follicles should be aspirated, as blastocyst rate in smaller follicles is also up to 40%. Now, But what is the best size of the follicles, especially in older women and in poor ovarian reserve women? This was a study where HCG trigger was given in older women. Very early retrieval 13 to 15, early retrieval 16 to 18, and standard retrieval 18 to 20. And they found the best retrieval was actually 16 to 18. Now, this is provided you don't have a discordant growth. That is important. And it had the highest pregnancy rate also. Converting IVF to IUI and poor response. Now, when you think of converting IUI to IVF, just look at the number of follicles. If there is one follicle, there is no difference between the IVF and the IUI. So go in for an IUI. But the moment there is more than one follicle, the IVF is much more successful. However, the woman should not be too old because there the results will be poor. So again, here this is another study of Richmond and a systematic review in 2018, which showed that 2 follicles or 3 follicles IVF is better. Should we abandon the cycle and start another cycle? That's another option. Don't go to an IUI. But what did they see? They found that proceeding to IVF or abandoning and trying again, it's the same. There isn't much difference. What does evidence say? GnRH agonist protocol for a poor responder, or antagonist, or dual stimulation, or mild stimulation? So this is Elbigi's chart of a poor responder. Pre-treatment protocols for Poseidon 1 and 2. Consider the ART calculator. Genotyping screening should be done because she's an unexpected poor responder. Antral follicle of more than 5. AMH, so this is of more than 1.2 with a history of suboptimal response. This is that we will consider androgens in select patients. Then what about the stimulation protocol? You increase in Poseidon 1, increase by 50 to 75. That is the younger age group. If there is no variant. If there is a variant, increase by 75 to 150 and use a recombinant FSH. Consider adding LH 2:1 ratio, recombinant FSH and LH from the first day of stimulation in women who have consumed more than 3000 IU or have a history of follicular stagnation. In Poseidon 2, older age group unexpected poor responders, start with a recombinant dose of FSH of 300 IU, consider dual stimulation and a recombinant LH of 150 from day 1. You can consider the antagonist regime, a GnRH agonist trigger, an elective freezing. You could do embryo pooling. You could consider PGT in older women and consider single blastocyst embryo transfer, especially if it's euploid. What about 3 and 4? Well, this is antral follicles are low, AMH is low. You can give adjuvant treatment in the form of androgens, growth hormone, CoQ10 in younger women. The long protocol, E2 and OCP pre-treatment may be considered in these patients because it is seen those with low ovarian reserve show dominant follicles very often. And an antagonist or a dual stimulation can be considered. In older women, well, androgens and growth hormones should be considered. CoQ does not help in older women. And long protocol, E2 OCP pre and antagonist and duostim again. In the stimulation protocol, start with 300 even for younger women. And you can think of a long acting, which we don't have in India, but a long acting FSH. And in group 4, 300 with 150 LH recombinant, both of them recombinant or a long acting. The long protocol HCG trigger should be given. Antagonist you can give either, or you can give a combination, and duostim you give an agonist trigger. Evaluate the FOI by ART calculator. If it is low, consider adjuvant treatments in the next cycle. Timing of retrieval may have been wrong, and that's why your FOI is low, and consider dual or double trigger because that may help in getting mature oocytes. Insufficient number of oocytes retrieved. Oocyte embryo accumulation should be done with the help of duostim, accumulate, and a non-long protocol if there has been a discordant growth. So coming to the IFS guidelines and the IFS take on it, this was it. 21,000 records papers were taken out. We did a search and removed 5,000 remained after duplicate removal. And the record screen based on titles came to 228 which were relevant. and we excluded those which were not randomized controlled trials and had finally 116. So here we said that the pre-stimulation management in poor responders, hormonal testing at baseline, uh, does it have a predictive value? The AMH levels do have a predictive value. The antral follicle counts do have a predictive value, and we have recommended them. The gene polymorphism and immunological test we have not recommended because there was not strong evidence for it. There was strong evidence against it. Estradiol pre-treatment again, and pre-treatment for oral contraceptives we have not recommended again because evidence was poor. Then antioxidant pre-treatment conditionally, we alternative medicine and lifestyle therapies we did not recommend. However, we put them as conditional because lifestyle based therapies are not harmful, neither is antioxidants. So we just left it because there was actually there was no evidence here. The last column is evidence. There was no evidence. With ovarian stimulation, is GnRH antagonist protocol superior to GnRH agonist protocol? Well, they are equally recommended. Mild ovarian stimulation, low dose gonadotrophins, equally recommended compared to conventional. There was very strong evidence on this. Mild stimulation of letrozole with low dose gonadotrophins and clomiphene citrate with low dose gonadotrophins equally recommended. But alone clomiphene and letrozole we did not recommend because there was actually no evidence to recommend it here. This last column. So we just give a good practice guideline saying that it is based on patient characteristics. If you're only seeing one antral follicle, might as well give her clomiphene and finish it off. Then is GnRH agonist flare protocol not recommended. Duostim, again, like I said, not recommended. Luteal phase stimulation, not recommended because we don't have the safety factor. Modified natural protocol, not recommended. And the PPOS, again, we did not recommend it because no safety data is there on the baby or how the long-term impact on the baby. What is the safety and efficacy of recombinant FSH compared to urinary gonadotrophins? Equally recommended. Mid-cycle addition of HMG recommended. Starting dose should not be beyond the standard dose. Higher doses are not recommended. LH and FSH compared to recombinant FSH, again, uh, LH and FSH is better, and that is what we recommended. Early and mid-cycle initiation, either day 1 or day 5, 6 should be done. Equally recommended. Long acting, equally recommended. Adjuvant therapy, growth hormone, testosterone, DHEA, CoQ, glucocorticoids not recommended again because there's no strong evidence for it. There's maybe strong evidence not showing that it helps. Monitoring stimulation protocols, addition of hormonal assessment not recommended. Conversion to IUI or cycle cancellation not recommended. Preferred drug for trigger, equally recommended. Dual trigger and conventional, we equally recommended seeing the evidence. Embryo transfer, elective freeze-all, not recommended. Oocyte retrieval, follicular flushing, not recommended. Routine ICSI, pre-implantation genetic testing, and in vitro maturation, not recommended for these patients, and strong evidence against it. Rejuvenation through platelet-rich plasma, intraovarian cell therapy, and in vitro activation, not recommended. Again, strong because there was very poor evidence for it. So can we help with ovarian rejuvenation stem cells? Well, these are still experimental, and I would not put them in my presentation because we are still fumbling, and maybe a few years down the line, we say, oh, this doesn't help. One of the secrets of life is to make stepping stones out of stumbling blocks, and that is what a poor responder teaches us. Thank you.
Thank you, ma'am. It's an amazing talk as always. It's always, to hear you. And I think you have covered all the points in this talk. Ma'am, I have one question that you have told ki, we should aspirate less than 10 follicle also.
Yes, I do it.
I mean, less than 10, 8 to 10 basically.
I do it.
Okay.
Especially in a poor responder. And
New
this is a personal experience.
Okay.
I get oocytes and I get embryos from those oocytes.
Oh, that's nice, fellow. I will also try
You'll
to
be
do it.
surprised when you aspirate. And in a poor responder, you're so desperate because you punctured one big follicle, nothing came out. So then I do all the smaller ones and they come out and they do fertilize.
Yeah, that's a new thing. I mean, because one or two follicles, sometimes I also didn't get any oocyte, and the smaller 10 mm I usually left. So I think,
And they are a little difficult to puncture. They're
yeah,
difficult to punch.
obviously this is difficult. Okay, ma'am. It's a nice talk.
Thank you.
Thank you, ma'am.
Okay. Thank you, Manjusha.
Dr. Manjusha is there, I think.
Dr. Surveen, a big
Yeah.
thank you to you. I understand how busy you are at Max also and at your this
Always there
POR
for you.
workshop also. I mean, really, really, thank you so much for being with us.
Thank you for
And
having
we
me.
really got to learn a lot. And you gave us such practical tips and all were evidence based. So I'm sure everybody must have really enjoyed listening to you. Thank you so much.
Thank you.
And
Thank you.
if you have time, I would request you to stay on and be a part of the
No,
other
I
proceedings.
have to go somewhere now. That's why I've got it a little preponed.
I know. Yeah. Okay. Thank you
Okay.
so much, Dr. Sylvian.
Okay.
Thank you.
Thank you.
Can I now request Dr. Kokila Desai? Hello, Dr. Kokila.
Hi,
Dr.
I think unmute is required. Yes.
Yeah.
Okay.
Dr. Kokila is a very senior fertility specialist, and she is the immediate past secretary of IFS Rajasthan chapter, Gujarat chapter, and she is here with us today, and she'll be sharing her views about ovulation stimulation protocols for an IUI. So over to you, Dr. Kokila.
Thank you, Dr. Manjusha, for inviting. It's a great thing. Today we are going to learn ovulation induction. Dr. Subhi Madam has nicely, elaborately explained the poor ovarian response and how to stimulate and how to go ahead in these patients. So today we are going to see ovulation induction in a patients of IUI. Can you share my PPT? Hello.
You will have to share your PPT yourself, Dr. Kokila. You are a co-host.
Shared it, but it's not coming. I think it's something else is coming.
You are a co-host. You just try sharing. You have sharing rights. Yeah.
If you're not comfortable, you can put it in the WhatsApp group and I will download and share it for you.
No, it's not coming, I think. Yeah. Can you see it
No, we can't. It's not yet there.
now?
No.
Sorry. Hello.
Yeah, Dr. Kokila, we can hear you, but we can't see the presentation.
Would you be happy to share the presentation, the
In the,
entire PDF thing to
Ma'am,
maybe
please
Padmaja?
come back to the Zoom and there is a sharing button.
I think I'm sharing, but it's not going.
Otherwise,
Only
just
something else.
now it is coming.
Now we
Yeah.
can see it.
Double, yeah, we can.
Now it's about to come.
Yes, now it's come.
Please make it full screen, Dr. Kokila.
Yeah.
Yes. So today we
Yeah.
are going to discuss about the ovulation induction protocols for IUI. So the problem, yeah. Basically, what we want, the aim of ovarian induction in ovulation induction is we get 1 to 3 pre-ovulatory follicle of 18 to 20 millimeter and triple line endometrium more than 7 millimeter. If we don't achieve poor response, like if we get only for dominant follicle or more than 3 ovulatory pre-ovulatory follicles, then it goes. We can say it's a poor response. If the endometrium is poor, again we will be having a failure of the IUI cycles. So superovulation, basically we have to go for the superovulation when you are planning to do IUI. Superovulation corrects the subtle ovulatory disorders. Superovulation increases the number of pre-ovulatory follicle. Increase in ovarian size may bring the ovary in close proximity to fimbria. And superovulation may also affect the tubal vascularity to enhance the ovum pickup mechanisms. Our goal is maximize beneficial effect of the treatment, strict cycle cancellation criteria, and avoid OHSS and multiple pregnancy. So whether you go for IUI with ovarian stimulation or you go for IUI in natural cycles, which one is the better? The newer guidelines of AHRM 2020 have said that if you are treating an unexplained infertility, go for IUI with ovarian stimulation. Mild endometriosis also, they have suggested IUI with ovarian stimulation. Male factor, ovulatory disorder, definitely you have to go for ovulation induction, and PCO also you have to go for ovarian stimulation. So basically, we need to do ovulation inductions. The physiology of ovulation, I'm not going in detail of it because we all know. The main thing is the two cell theory, which explains how theca and granular cells in the ovary working with the hormones LH and FSH produce estrogen. LH stimulates theca cell to produce androgens, which are then converted to the estrogen. And so in the early phase, the LH will produces androgen, which get converted to estrogen. And in a later phase, the FSH itself stimulates the granular cells, and there is a more stimulation of estrogen taking place. To understand the ovulation induction with the when we are using a gonadotropin, we have to understand 4 parameters of the FSH administration. The choice of FSH starting dose, second is the duration of the starting dose before stepping up or stepping down, the rate of increase in FSH dose at each increment, and the reduction of the FSH dose once the follicle has been selected. So the FSH threshold window should be clearly understood in the window concept should be clearly understood before going for ovulation induction. FSH, whenever it crosses the threshold, then and then there is a dominant follicle selection takes place. Once the FSH cross the threshold, all follicles which are available will keep on growing. So if in IUI cycles we don't require more follicles, we require less number of follicles. And so this threshold, once the threshold cross, dominant follicle selection takes place, then this FSH should go down so that the middle size follicles and smaller size follicle will get atresia, and we can get a monofollicular or two follicular response. So the understanding of this FSH window continuous, the FSH should remain above the window is required when you are doing a stimulation in IVF. But when you are doing a stimulation, especially in IUI cycle, this window should cross and this FSH should go down. And that is how the dominant follicle selection takes place, and the other follicle should go in atresia. So there will be there won't be a multifollicular response. What are the important factors to be considered before ovarian stimulation? Ovarian reserve, one should look for the ovarian reserve AMH value, serum FSH, previous ovarian response, basic hormone profile, TSH, triggers, luteal phase support, and pregnancy rate. The oocyte, one should also keep in mind the effect of selected drugs on oocyte quality, embryo quality, effect on endometrium, and cost effectiveness of that particular drugs. Which are the stimulation drugs available? There are many ovulation available like letrozole, clomiphene citrate, commonly known. Then letrozole with gonadotropin, CC with gonadotropin only, agonist with gonadotropin, or you can go for antagonists and gonadotropins. CC, we all know the physiology. I'm not going in detail of it, but the effective dose of CC range from 50 milligram per day to 250 milligram per day. The most of the times we don't go beyond 150 milligram per day. So 50 to 100 or maybe 150 you can consider, especially in a very poor responders of PCOS patients. Although higher doses are sometimes required, but the success rate are usually very low when you go higher than 150 per day. Pregnancy rates are highest in the early cycles of CC treatment. In general, in women treated with this conventional CC step-up regime, the 55 to 73% of the patient will definitely ovulate. We are not going in detail of the functions, but mainly it is acting on the hypothalamus and pituitary and increase the internal gonadotropin secretions. The studies of CC and intrauterine insemination, the analysis of more than 4,100 cycles have shown, and the author has concluded that the majority of the pregnancy are achieved with each age stratum occurs within 3 to 4 initiated cycles. And as anticipated, younger patients have a higher pregnancy rate as compared to the older patients. So basically, it says that all pregnancy will take place within 3 to 4 cycles. If patient do not respond or do not get pregnancy within 3 to 4 cycles, there is no point wasting more time, and you should switch to the other modality of the treatments. This was the committee opinion. So the committee has opined in 2020 ASRM guidelines says that clomiphene citrate is an effective first-line treatment for the majority of the women with anovulation. CC can be used in unexplained infertility along with the IUI and failure to conceive for 3 to 4 cycles. Then should switch to the other modality of treatments. The combined therapy involving CC with metformin, exogenous gonadotropins, or glucocorticoids have shown a better result compared to the only clomiphene citrate, especially in PCO patients. And so the ASRM 2022 recommended that it is recommended to use CC with IUI in a treatment of couple with unexplained infertility. Risk and complication, basically it's a multifollicular response and multiple gestation is the main problems. No birth defect has been found to be associated with CC, no miscarriage. Mild OHSS has been seen, but rarely you can observe the severe hyperstimulation syndromes. No causal relationship between ovulation induction drug and ovarian cancer has been established. The another ovulation is a non-steroidal letrozole with aromatase inhibitors, which blocks the conversion of androstenedione to estrogen, and that's how increasing the pituitary FSH and LH. Used for treatment of breast cancers, especially in a postmenopausal woman, but it does not block the estrogen receptor. And so the most beneficial effect is no detrimental effect on endometrium or cervical mucus has been found by aromatase. Negative feedback mechanism not turn off, so less chances of multifollicular development. Letrozole is used in a dose of 2.5 to 5 milligram per day for 5 days, starting from day 3 of the cycles. Extended letrozole therapy, long letrozole protocol, where you can use 2.5 milligram for 10 continuous days. Then letrozole step-up protocol, which was suggested by Mitwali et al. And he has proposed the step-up protocol of 1, 2, 3, and 4 tablets. That is 2.5, 5 milligram on day second day, then 7.5 and 10 milligram respectively from day 2, 3, 4, and 5 respectively. And it was associated with a multifollicular development and high clinical pregnancy rate. Here is the pictorial presentation. Like letrozole, you can give for 5 days. You can give letrozole along with the gonadotropin. So initial 5 days letrozole, and then you can add the gonadotropin as per the requirements. Or you can also use letrozole with gonadotropin and antagonist. We will see later how to use the gonadotropin. Then another is a step protocols where the letrozole is given 2.5 milligram for 5 days. Then do the sonography. If the dominant follicle selection has not taken place, just give the letrozole 5 milligram for next 5 days. That is from day 10 to 12. And you can see that once the dominant follicle selection takes place, then you can just go ahead and complete the cycle. Same as can be done for the CC cycle also. Coming to the injectable gonadotropins, when can be used? Gonadotropins could be used as a second-line pharmacological agent in a woman who have failed first-line oral ovulation induction therapy. Or one can also add gonadotropin to oral ovulation to optimize the response of the ovulation inductions. Factors to be kept in mind while using gonadotropin: the cost and the availability, expertise required for the use of ovulation induction, degree of extensive ultrasound monitoring is required, lack of difference in a clinical efficacy of available gonadotropin preparation that should be kept in mind. Low dose gonadotropin protocol optimize the monofollicular development, and the risk and implications of the potential multiple pregnancy should be also kept in mind when you are using gonadotropins. Actions of both are the use of oral ovulation with gonadotropin. Basically, the action of both are complementary to each other. Difficult to titrate, but starts with you can start with softer stimulations. No standard guideline available for combinations, and so you will required to monitor very carefully. The regime, like you can give first 5 days clomiphene, and then you can add the letrozole on day 7, 8, or 9. Many people are using it for day 2 to day 6 tablet, and then day 7 alternate day. And also people are using the CC with alternate day gonadotropin add-on. Just this can help to cross the threshold value of the FSH window. Oral ovulation induction agent in a combinations with the gonadotropin in a ISHRI guideline has consensus says that while comparing the CC versus CC and gonadotropin, the conclusion have been drawn that there was no significant better effect. There is no significant detrimental effect, but there was no benefits by using these two combination. But in practice, we often combine oral ovulation with gonadotropin to cut short and bring the dose of gonadotropin with a to reduce the dose requirement of gonadotropin with variable success rate. Gonadotropin protocols, step up protocol or step down protocol can be used. In a step down protocol, you can start with 100 or 150 IU of FSH and give it for 5 days. And once the follicle reach more than 9 millimeter, you can reduce the dose by 37.5 IU for next 3 days. And again, if the follicle is growing well, you can again reduce the dose by 37.5 in the next 3 days till you achieve a leading follicle of 18 millimeter, and then you can give the trigger. In a step up protocol, you can start with 50 or 75 IU of FSH or HMG and then give it for 5 days. And then once the follicle is less than 9 millimeter, you can increase the dose. If follicle is more than 9, you can continue the same dose. Increase the dose by 37.5 at every 5 to 6 days interval until the dominant follicle of more than 10 has been crossed. Then you can continue the same dose for the rest of the period till the follicle reaches to the 18 millimeters. Step up protocols, the starting dose is 550 unit. It is a better because here in step up protocol, it is a softer stimulation, low dose, low risk of OHSS, but the only disadvantage is sometimes you may have a failure of the cycles if your follicle is not able to cross the FSH window. Sequential step up and step down protocol, which you can combine both the protocol. Initially start with the step up, that is increase the dose. Once the follicle reach to the 9, you can continue the same dose. And once the follicle reach to the 14 millimeter, you can cut down the dose to half, because that is required for the maintaining and reaching up to the 18 millimeters. So that can be combined, can also be used. Chronic low dose therapy can be used in a protocol, especially in a PCO patients. Adequate response with gonadotropin can be achieved once if you have a 1 to 3 follicles more than 15 millimeter rising estradiol layer, then continue the same dose for next 2 to 3 days. How to avoid complication with gonadotropins in IUI? Low dose protocol to avoid OHSS and multiple pregnancy when more than 2 dominant follicle of more than 15 millimeter, or if there is a more than 5 follicles of more than 10 millimeter had been seen, then you should withhold the giving triggers and cancel the IUI. Indication of use of gonadotropin antagonists in IUI cycle. Prevention of premature ILS, especially when gonadotropins are used. Asynchrony between the endometrial thickness and follicular maturation if seen, then you can use antagonists. And to manage the timing of IUI if it's weekend is coming. The main advantage is whenever the follicles have only the dominant follicle is the most sensitive to the LH. The LH sensitivity is not been seen in a follicle which has been grown more than 12 or 15 millimeter size. The middle size follicle remains sensitive. So once your dominant follicle selection has been taken and then you give antagonist, the middle size follicle that is between 10 to 12 or 14 millimeter will start getting atresia and they will get arrested. The only dominant follicle will continue growing, and so you can have a better monofollicular response or two follicular response rather than a multifollicular response. That is agonist or antagonist both can be used. And this is the way you can use you start the gonadotropins and then you can once the follicle reach to the more than 40 millimeter, you can add antagonist, and once the follicle reach 18, you can give the trigger and then plan IUI accordingly. Ovulation trigger, HCG versus agonist, which to be used? The HCG, the agonist trigger is a surrogate. The HCG is mainly a surrogate LH surge. It is administered as close as possible to the time of ovulation, that is 36 hours before doing IUI, and its activity lasts for several days throughout the luteal phase. You can use urinary HCG or you can use recombinant HCG depending upon your choice, depending upon the patient's money, as well as depending upon the case. In a poor responder, I usually prefer to use recombinant HCG. But if the patient is a normal responder, I use urinary simple HCG. And if the patient is PCO, I prefer to use agonist trigger rather than HCG. The agonist trigger, in contrast to the HCG agonist induced surge more closely resemble the natural mid-cycle surge of the gonadotropin and expose follicle to both LH and FSH. However, after GnRH agonist trigger, the surge of gonadotropin is shorter in duration and there is often poor LH support for the corpus luteum, or actually luteolysis happens early, and so patient will require definitely luteal phase support is required. Dual trigger can be used if that is like using an agonist with half the dose of HCG. Dual trigger is preferred especially in cases of PCOD patients. When to do inseminations? You can do insemination IUI between 24 hours to 40 hours depending upon your protocol. I prefer to do it 36 hours. And so if the ovulation has not been taken place at 36 hours, then I sometimes ask the patient to wait for 3-4 hours. And by the time 40 hours is over, then I definitely, whether the ovulation has taken place or not, I go for IUI. Adjuvants in poor responders, antioxidant CoQ10, growth hormone also shows better clinical outcome in terms of achieving pregnancy, and a lower dosage of gonadotropin is required for the ovulation induction. I think about the growth hormone, Dr. Suvin madam has already discussed everything in detail. Testosterone and DHEA can be used. Recombinant LH can be used if you think the patient is a poor responders. Then adjuvant in PCOD, melatonin, N-acetylcysteine, myoinositol, methyl folate, alpha, calcidol, that is vitamin D, etc., has been shown different helping the PCO patients. So if you're stimulating the PCO patient, you can think of using Bigomet or melatonin along with N-acetylcysteine. Metformin and inositol both are helping in a PCO patients. And sometimes if the LH is high, you can use corticosteroids along with the stimulation in the initial 5 days. Then luteal phase support, very important. Why it is required? Ovarian stimulation, especially with the gonadotropin, can disrupt the normal luteal function due to the altered LH secretion and premature luteolysis. What to use? Microdose vaginal progesterone can be used 100 to 200 milligram or oral dydrogesterone 10 milligram twice a daily. When to start? Start 1 to 3 days after the IUI. Continue until the pregnancy test comes positive. And if it comes positive, extend it till the like almost at 8 to 10 weeks. Evidence supports use of multiple studies have shown that it improves the pregnancy rate with the progesterone support in a stimulated IUI cycles. And it is safe and well tolerated by all the patients. So take home message is optimizing ovulation induction in IUI. Individual protocol are the key factor. Choose stimulation protocol based on the age, ovarian reserves, that is anti-lutein hormone, AFC, BMI, and previous response. Start low, go slow. Use the lowest effective dose of gonadotropin to avoid hyperstimulation and multiple pregnancies. Letrozole is the first line of ovulogen in a PCOS patients. Safer and more effective than clomiphene in PCO patients, it promotes monofollicular growth. Monitor closely. Regular follicular scans and hormone monitoring improves the timing and reduce the risk of OHSS. Trigger timing matters, so HCG should be given when leading follicle is 18 to 20 millimeter with a good endometrial thickness that is more than 7 millimeter. Limit follicular number. So if there is a mature means more than 3 mature follicle, more than 15 or 17 millimeter is present, then avoid high order, which can lead to the high order multiple pregnancy. So avoid giving trigger and doing IUI. Luteal support is critical. So the last word of to ovulation induction is, if the diagnosis is correct, most cases will ovulate. Aim is not to achieve ovulation at the cost of increase in complications. Days taken to ovulate do not matter. And ovulation induction is not only a science but a piece of art. Thank you very much for patient listening. Hello.
Yeah, thank you, Dr. Kukla, for such a comprehensive talk. Dr. Divya here.
I'm covering the sonography monitoring because it was ovulation induction, so I had just left that part.
Yeah, that's a very brief, very concisely you have described everything about the ovulation and stimulation in protocol. I just wanted to ask one question. Do you
Yes.
prefer to use the extended protocol of letrozole or the step-up protocol of letrozole while this is stimulating in cases of IUI?
Yeah, IUI, I definitely use letrozole step-up protocols. I give for 5 days, and if the patient do not respond, I give 10 milligram for next 5 days. Because when the patient is mentally prepared for the IUI, I usually give maximum dose of trial in the first cycle. And once the dose has been decided by giving a first cycle, like when she when she is able to, at what dose she is able to cross the FSH window. After that, in the second cycle, we directly start from that dose.
Yeah. So, So what do you think? Matlab, I have actually used in few of my patients, but I was not very satisfied. I have seen rather using this gonadotropins along with the letrozole is a better option than rather than extending the dose of the
Yeah, so
letrozole. What do you
when
think?
the patient is taken first time, I usually give higher dose. Like if I start with a 10 milligram, normally I give 10 milligram in a first 5 days, that is one BD. And if patient do not respond, then I give two BD for next 2 days, like that. And
Hmm.
if the patient is ready to directly go for the gonadotropin, or if the patient has taken ovulation in other places or others, this cycle has been done in other places, then I directly
Hmm.
explain them and take them with oral ovulation with gonadotropin.
Yeah,
If it's
that's
the
a better
first cycle,
option.
then I usually give the higher doses, like go for step
Yeah.
dose.
And normally you prefer to do start with the 2.5 mg or letrozole.
Uh,
Normally I prefer to use
Depending
the 5
upon
mg.
yeah,
Yeah, that
depending
is.
upon BMI and all that, like if the PCO, I usually prefer
Yeah.
2.5 BD for 5 days, that is 10 milligram
Uh-huh.
daily for 5 days. But if the patient is thin lean or BMI is less, or if the patient is a very young patient, then
Yeah.
I give 2.5 OD for 5 days.
Yeah, definitely. Yeah. And the GNR is normally the trigger is given by SCG. You use GNRH agonist only when the case of PCOS.
Yes, only in PCO. Otherwise, I give a trigger HCG trigger only.
Yeah. Yeah.
But when I
Okay.
see more follicles like 3, 4, 5, then sometimes I use antagonist.
Yeah.
I just
Okay.
give antagonist as to reduce the LH sensitive, because the middle size follicles are LH sensitive. So I want them to get atresia so that I can have only 2 or 3 follicles and patient will not go for OHSS.
There was one question in the chat box that which gonadotropin you prefer during the IUI. What is your choice of
In the
gonadotropin?
sense, company's name, I prefer HMG basically. I don't go for
Basically.
FSH. I use a recombinant FSH only in patients of PCOS.
Yeah. But
As full
otherwise you use
responder
the
as
HMG.
well as normal responder, I use HMG.
Yeah. Very nice. Any other question?
And I prefer a step down protocol. Normally, I start with 150 and then reduce the dose.
Mm-hmm.
Step up is
Yeah.
not
I
my
think.
preference.
Yeah. Normally, the thing which is said, like using the chronic low dose step up protocol in PCOS, do you normally practically use it
No,
during the
because
IUI?
patient, I think the patient will disappear and will get bored by
Yeah,
using it for 10 to
it's
15
very
days. So
theoretically, it's very
practically,
nice,
it
but
is
it's
very
very difficult.
difficult. Yeah, it is
Uh,
theoretically, it sounds good, but practically, I had not seen a very good response with the low dose.
yeah, it's always better. The step down protocol is still better, I think. Yeah. Dr. Manjusha?
Yes, thank you very much, Dr.
Yes.
Manjusha, Dr. Divya,
Thank you
Dr.
so much,
Thank you.
Dr. Kokila. It is always a pleasure to hear from you, and you always
This,
give us such practical tips and so much to learn from you always.
Thank you
And
so
thank you,
much.
Divya, for that wonderful discussion that you conducted. May I
sorry, Dr.
now?
Manjusha, there's another question in the chat box. That how long you go for chronic low dose protocol if you're going for chronic low dose, for how long you go for it?
I think
There's
10
one
days.
question in the chat.
Yeah, I had initially when I was like initial user of the gonadotropin, I was scared about the gonadotropin. In those days, I had used small doses like 50 and 75, but not given more
Mm,
than 10 days.
mm,
There's no response in a 10 days. I had cancelled the cycle,
yeah.
and then in
Uh,
a next cycle, I had started with the one like higher doses. That is what I
I think
did.
most of us are in fertility, especially they do not use the chronic low dose step up record because it is not very practical. Yeah.
Yes.
No, Dr. Manjusha?
Yeah. Thank you so much, Dr. Kokila and Dr. Devya. And I think we can now move on to the one of the
Awaited
most
program of
awaited
the quiz.
bits of
Yes.
this event,
Yes.
and that is the quiz. And we have none other than the very, very energetic quiz master, Padmaja, with us. And Padmaja, would you be happy to take off right away?
Yes. So I hope all of you have the Kahoot installed in your cell phones and you're ready with that. The correct answer matters and how quickly you put in also matters. So you need to, the most scoring system is for the correct answer and the fastest finger. So we will have 3 winners and we have 20 questions. And please log in with your phone number so that your when it asks you for your pin, that nickname is written, no? So in that you have to, the game is getting loaded, and you have to enter this pin 758917, and in your name, please put your phone numbers. Okay. So we have 38 participants and I'm looking forward to seeing you all. Yes, we have the first person who entered. So once the number of participants have entered, we will lock it and then we cannot entertain anymore. Okay. Okay, so we have 15 participants and are any more? Sini, Vicky and NB, can you please log in with your phone numbers? Because later when we need to communicate, it becomes very difficult if we don't have the phone number. Can you log out and put on your numbers? Oh, Shivam, you've taken off the Kahoot? Yes. Only one person, NB, needs to change their number. It's 8 o'clock and we are right on time. Yes. So we have 15 participants. Are we having any more? The other 33, other 15 people are just watching the fun. Yes, some more. That's nice.
Padmaja, I think we can wait for 2 minutes more because two people have just joined in.
Okay, okay, okay.
Yeah.
So for the people who just joined, some of the things that are really very nicely told by Dr. Surveen were that if you believe in DHES, that it is going to give us an extra oocyte or two, you need to use it at least for 4 to 5 months and then start your stimulation protocol. And the maximum effect is seen only up to 10 months. That using it for 2 or 3 years or 4 years hardly makes a difference. So if it is not making a difference at the end of 1 year of use, we should not be saying banking on it too much. That was one point that I really liked. The other one is in young people who are having an unexplained poor response, and you're thinking there is an FSH or LH receptor polymorphism which is leading to poor response, starting dose, whatever you've used previously, increasing it by rec FSH of 50 will help us get one more oocyte. And maybe in some of the poor responders, some of the empty follicles, we will have lesser number and more oocytes if you use a rec FSH of a rec HCG of 500. We're using Ovitrel 250. So maybe giving 500 might make a difference. So I think these are the options we can try in a person previously who has not responded well. And aspirate all the follicles you can aspirate. That is the dictum, because sometimes the best follicle might not be having an oocyte. It might be an empty follicle. Even a 10 mm follicle can give an oocyte. And if the oocyte has a well expanded cumulus, the embryos and the blastulation rate and the implantation rate are good from that. Then when we have a single follicle with no male factor, IVF, IUI give the same pregnancy rates. When there are more than 2 follicles, then an IVF will give a better pregnancy rate in that situation compared to an IUI. And if you've used more than 3000 IU of gonadotropins in the previous cycle, start with an FSH-LH, recombinant FSH, recombinant LH 2:1 ratio from day 1, and your response might be a little better. So these were the things that I really liked when we are dealing with the poor responders, and there every oocyte counts. That is it. And the person who logged in with you, can you please log in with your phone number? So if that one number changes, I think we're good to go. Whenever you say, Dr. Manjusha, we will start. Yes.
Yeah. I think we should start.
Yeah. How come someone left also, some 2017? Maybe they are changing the number. Yeah, and even in the chat box, no one said to wait. Yeah, now we have the 18 back. And I think we can start. Yes. So let's get started. From which antral follicle size does AMH correlate to? The last 5 seconds. 2 people haven't answered. Yes, you got it. And most of you have the right answer. It is 2 to 6 millimeters. The next. Follicular atresia happens at a steady state, and that steady state before an escalation is maintained till what age? Yes, it is. The cutoff is after 35 years. Next. So getting the answer right is important. Quickness also is important. Best clinical pregnancy rate in assisted reproductive technology. We have 15 answers, 2 more to go. Yes. And all of us agree, nothing can beat age. The younger the person is, the better quality oocytes we have, the higher chance of pregnancy. Next, please. In conventional IVF protocol, poor ovarian reserve includes all except. So what are the ones that we would use for poor ovarian reserve? So next, please. You have the answer. Poor response, during ovarian stimulation, what is the maximum dose you can use for response? I think all of you should be very familiar with this. Most of the studies say increasing it to more than 450 does not make a difference. So 300 is what we will routinely start off, but the maximum response, maximum dose you can go up to is 450. Next. Pre-treatment testosterone, maximum benefit is seen till what, in which, how many weeks of use, at least how much do you need to use? So most of you have it right. It is at least 4 weeks. Next, please. Next. Shivam, is your system logged? Okay, fine. In natural cycle IVF, what is the clinical rate per embryo transfer? Yes, most of you have it right, 14 to 20%. Next. Limitations of natural cycle IVF include all except. Yes, in natural cycle, since there are lesser follicles, that is why we are picking up, we will be getting less number of oocytes. Next. So we have someone with 8110 who's having the right answer streak of 3. So you're close to the top. That's good. Next, please. Next question. Shivam, is your network slow? Hmm. The next question. One question got missed. Okay, fine. Measures of antral to attain and follicular synchronization include all, sorry. Which all can we use? It is estradiol 4 milligram. Next question, please. What is the initial trigger in dual stimulation? Yes, most of you have it correct. It is GnRH-A, because you're planning to go ahead with another stimulation, which you can't do with the HCG, which has high LH activity. Next, please. What happens when we have too little LH? Excellent. So we have impaired steroidogenesis. That is the reason we need some amount of LH. Next, please. What are the indicators of diminished reserve? It should be high LH with a high E2, because it is indicating that the follicles are getting recruited much faster. Next, please. In long GnRH agonist protocol, why are we not using it so often in poor responders? What's the limitation? Yes, almost all of you have it correct. It is because of the cyst formation and pituitary suppression, profound suppression. Next, please. Which is the theory that explains the luteal phase stimulation in dual stimulation? Very good. Antral follicles, they retain their responsiveness to gonadotrophin. So that's why we can continue to stimulate them. Next, please. In progestin primed ovarian stimulation, how is the LH surge prevented? It is because the pituitary secretion is, LH secretion is by the negative feedback one. So this is how in PCOS also the same theory works. They don't have progesterone, so they have high LH. Next, please. The one hormone that you would do if you want to predict the oocyte yield, which is in direct proportion. Not everyone does the hormones before trigger, but if you were to do. Yes, it is the pre-trigger estradiol level. Next, please. Pole scope is a microscope. Does it visualize in the oocyte? It's the polar body, not the spindle. Sorry, it's the mitotic spindle. Next, please. Fragile eggs with increased oocyte degeneration after ICSI are more likely to be seen in which medical condition? They're basically in poor ovarian response. Endometriosis is associated with darker oocytes. And we are coming to the last question. Next, please. Class 3 Posidion includes which type of women? Very correctly, less than 35 with poor reserve. And can we have the winners? The first winner had 17 out of 20 correct, and that is amazing. The second one had 15, and the third also 15. So this was a very close finish. Thank you very much for participating. And Dr. Manisha, do you want their names in the chat box?
I want the names as well as the email addresses in the chat box so
Yes.
that we can be mailing their e-certificates to them as soon as we can.
Yes.
And also, we would be inviting all the winners, the top two or the top three ones, in the grand finale of Genius Junction would be held in November on the third Thursday. So, all the 10 Genius Junctions done from January till October will be identifying two or maybe three people, and they will all battle it together to the Genius Junction finale. So, that's what we have planned. So we need to communicate with you guys. So that is why we need your emails as well as the phone numbers. Padmaja, there's a query
Yeah,
raised
there is
by
a
one of the
query.
contestants.
Yeah. But when you
It'd be
look
nice if you
at,
could quote the reference.
yes, the 300 is what is given in the guideline according to some groups, but people have already also tried up to 450. I will give you the reference so you can read up that articles also. Okay.
Before we guys close, only Dr. Rakhi has given me her phone number and email. I need phone numbers and emails of the other two also. Rakhi, Shivangi, and who's the third one? Please put it in.
Rakhi is first, Shivangi is third, Rekha is second. There you have Rekha.
Yeah, let me just click.
Yes.
So you guys will be getting your e-certificates as soon as they're ready. And then we'll be inviting you to the finale of the Genius Junction.
Yes.
I hope all of you are registering for Fertivision, because in Fertivision also we have a interesting quiz being planned for you all.
Yes.
Yeah.
Yeah.
Thank you, Padmaja. You're fantastic. I wonder from where you choose such questions. And I love the poise with which you conduct it. And it's so informative, always, always. I mean, hats off to you.
Thank you, Dr. Manjusha. So see you back next month.
No, before that, Mona, are you with us? Mona. Dr. Mona.
Yeah, she can unmute or
Dr. Mona, can you unmute yourself?
maybe they're not the
Raghav, can
person.
you unmute Mona?
Oh, Dr. Mona is unable to unmute.
The host,
Yes,
are you?
so
Yeah.
good evening, everyone. And it was really a wonderful session. I actually enjoyed both the lectures and the quiz a lot. And I didn't fare very well in the quiz. So, yeah, it was actually, the speed with which you have to do, no? It was my first time that I tried
Okay.
Kahoot.
Yeah.
So, but it was really good, Dr. Padmaja, and it was a revision of all what we practice and what we learn.
Yes.
So, thank you all, and thank you, Dr. Manjusha, for this wonderful event. And I invite all of you for the next months. That will be on the third Thursday, 21st of August, and that will be on ultrasound. So it will be along with the SIG ultrasound, and let us all meet then.
Yeah. Thank you. Bye-bye and have a good evening.
Thank you
Bye-bye.
so
Good
much.
evening,
Thank
everyone.
you all. Yeah.
Yeah.
And I must thank Mr. Raghav Himanshu for putting up this show for all of us. Thank you.
Hello.
Thank you, ma'am.